Welcome to an educational presentation about childhood overweight and obesity and the medical identification, diagnosis, and management or treatment. Over the past 3 decades, many children have developed unhealthy eating habits and have developed sedentary activities for entertainment habits. This has led to a public health crisis of alarming increase in the number of overweight and obese children. This educational program has been developed to assist the practitioner with identifying, diagnosing, and treating children with overweight and obese problems. Please take a few moments to review the 6 objectives. Over the past 2 decades, we have had a steady rise of the number of obese adults in the United States. If we look at these maps, we can see in 1990, we had 10 to 14% of our adult population being overweight or obese in Iowa. By the year 2000, this population was 20 to 24%, and by the year 2010, it has risen to 25 to 29%. We also know that overweight and obese children have a greater tendency to become overweight and obese adults. Thus, the epidemic for the adult population is going to increase as the epidemic for the child population increases. We are also approaching a time in our society when we have a shorter lifespan expected for the children than we do for their parents. Some children are at higher risk than others as far as being overweight or obese. Disproportionately being affected are those who are Native Americans, Hispanics, African Americans, lower socioeconomic groups, and children in the South. The older the overweight or obese child is, the more likely he or she will become an overweight or obese adult. This slide depicts the relationship between the age of the child and the likelihood of developing overweight or obesity as adults. As you can see, 8 out of 10 overweight teens will become overweight adults, whereas 1 in 10 infants who are overweight will become an overweight adult. We all find ourselves asking why. What are the risk factors for overweight and obesity in children? And then how can we handle these? This slide depicts the risk factors that have been identified as leading to overweight and obesity in children. The 2 highlighted, environment and behavior, are the 2 leading causes. Environmental risk factors are things that tempt children to indulge in unhealthy foods. A study done by Kaiser Family Foundation found that children aged 8 to 12 view the most food ads, and on the average they view 21 ads a day, or more than 7,600 per year. The Advertising Coalition reports that $10 to $15 billion is spent annually on kids' food advertising. Behavioral risk factors include regular consumption of high-calorie foods, fast foods, baked goods, vending machine snacks, all contribute to weight gain. High-fat foods are dense in calories and also contribute. When we load up on soft drinks, candy, and desserts, we get weight gain. Food and beverages like those that contain high sugar and high calories, and the environment that promotes high caloric foods contribute to weight gain. Also in behavior is activity. Sedentary kids don't burn calories through physical activity, thus they require less calories. Inactive leisure activities such as watching television, viewing video games, all contribute to the overweight and obesity epidemic that we are now seeing in our children. Obesity is the fastest growing public health problem in the United States. It affects us economically, physically, and psychologically. Economically, the epidemic has a direct effect on healthcare costs. The equipment we use to care for people who are obese is bigger and sturdier and more expensive. Obese care poses health risks to the healthcare providers themselves through occupational injuries and illness. Obesity also has great risks for many comorbidities, which cost more money through chronic illness. The direct costs of childhood overweight and obesity are related to the prescription medications for illnesses, emergency room care, and outpatient care services that are caused through their obesity. This is estimated to be about $14.1 billion annually. The inpatient costs are another $237.6 million annually related to overweight and obesity in children. The indirect costs of overweight and obesity also include those things that are affected in our society through the expenses that we incur for delayed skill acquisition in preschool children, requiring more attention to their needs, and the absences that occur with overweight and obese children from school in general, requiring additional time and energy spent to catch them up in their learning activities. The physical effects of being overweight or obese for children are that they are at risk for developing illnesses such as hypertension, metabolic syndrome, diabetes, and fatty livers. Many of the comorbidities are now becoming common medical health problems for older children who have been overweight and obese for a number of years. 12% of overweight children have an increase in blood pressure systolically. 9% have a diastolic blood pressure increase. Coronary heart disease is also identified in overweight children. However, the long-term effects have not yet been identified. Higher BMI in childhood has also been associated with increasing risk for coronary heart disease in adults. Kidney problems are more likely to be a complication of diabetes when diabetes occurs early in a person's life. As teenage children are now developing diabetes, they are at a greater risk for developing kidney problems, which will lead to more problems with kidney failure and dialysis in later years. They also are at a risk for this problem just in relationship to their weight alone. Also, the non-alcoholic fatty liver disease leads to liver failure, which will be on the increase as children develop more fatty liver problems from their obesity. There are also psychosocial health consequences for overweight and obesity. It can affect the quality of life through limited mobility and decreased physical endurance, as well as through social, academic, and job discrimination. Obese children are less likely to have good self-esteem. They experience more loneliness, and they have more social discrimination. Adolescent females who are overweight have reported through studies that they have more weight-related teasing, jokes, and derogatory name-calling as a result of their obesity and overweight. Overweight children are at risk to be victims of bullying, but we also have found that overweight children are at risk for becoming bullies themselves. These behaviors may hinder social and psychological development. Especially vulnerable to the consequences of biases are the children, as their psychosocial development has not yet matured. Negative attitudes towards obese youth develop in children as young as 3 years old, and these children have determined that overweight and obesity has negative characteristics. They talk about their overweight peers as being mean, stupid, ugly, unhappy, lazy. Many groups have begun to encourage healthcare providers to address the public health problems. This has resulted in numerous guidelines being developed by various groups. This slide lists the groups that have developed some guidelines that have been utilized in our healthcare setting. All are similar in recommendations for identification, terminology for diagnosis, and the treatment. The general focus is to get our attention to identify, diagnose, and treat, and to maintain health of children who are at a normal weight without health risks of overweight or obesity being identified. I have chosen to present to you the guideline that has been adapted by the American Academy of Pediatrics, Pediatric Obesity Clinical Decision Support Chart, which is depicted here on this slide. This slide has 3 columns. The first is identification, which leads to diagnosis. The second is what needs to be assessed once the identification has been made, and the last is how to prevent and how to treat what has been identified. In this slide, you'll see that those with BMIs from the 5th percentile to the 84th percentile are considered to be normal children. Those from the 85th to the 94th are considered to be overweight, and those from the 95th on are considered to be obese. In the center, the assessment talks about medical risk that needs to be assessed, behavioral risk that needs to be assessed, and attitudes of the family and the children that need to be assessed. And lastly is the prevention. For those that are normal, we want to prevent overweight and obesity from occurring, and we still need to talk about the risk and behaviors and attitudes when we're dealing with these children. For those that have been diagnosed with overweight and obesity, we then have a staged-based intervention plan. Stage 1 is prevention, which also applies to those of normal weight. Stage 2 is for those children who are overweight, and some may need to lose weight, some may not need to lose weight. Stage 3 is a multidisciplinary intervention approach, and that is for children who are overweight or obese and need weight loss. And stage 4 is for those children who are having a difficult time with losing weight and normalizing. After identification of the condition based on the BMI percentile, diagnosis and coding are completed, and then treatment must ensure and is planned for those overweight children with health risks and those obese children. Treatment can be staged according to the diagnosis, but first of all, stage 1 is for all children from ages 3 months on. Stage 2 is for those identified as overweight with health risks and obese children who are ages 10 years and older. Stage 3 is used for weight loss for children who have been identified as being overweight or obese, and stage 4 is used when the situation is complicated or there is lack of progress with stage 3, and this involves the use of a multidisciplinary team approach by persons specializing in weight loss for children. Let's get back to the identification of children who are at risk or those who are overweight and obese. We know that in order to determine BMI, which is what is used for the identification, we have to do height and weight measurements at least annually. From the height and weight, we compute the BMI. Once we compute the BMI, we use a growth chart such as that depicted here to determine the CDC percentile for the child. We then interpret the percentile and we determine if they are of normal weight, which would be less than the 84th percentile, if they are overweight, being the 84th to the 94th percentile, or if they are over the 95th percentile, meaning that they are obese. Without identification, overweight and obese children cannot be diagnosed and appropriately treated. With identification, diagnosis and treatment can be documented. With proper documentation, care and treatment of the overweight and obese child is a billable service under most insurances. When identified, the provider needs to be able to talk with the parents. Most parents indicate through research studies that they desire this conversation. The conversation needs to evolve around nutritional needs and controls, activity rather than sedentary time, and advocacy for family involvement in the treatment, which requires lifestyle changes for all in the family. Once we have identified the fact that a child is overweight or obese, and we have determined their BMI, we can then assign an ICD-9 code to their particular problem. With the assignment of an ICD-9 code, their care then becomes billable. While getting paid for this service is not perhaps our number one concern, it is a legitimate concern in that if we are not able to generate revenue from providing this care, we will not be able to continue to provide care to the overweight or obese child. By identifying a diagnostic code for overweight and obesity in children, insurance companies have recognized that this is a public health epidemic and needs to be addressed by the healthcare practitioner. Once we have assessed the particular child and determined if they're overweight or obese by determining height, weight, BMI, and on older children blood pressure and pulse, we need to assess their family history, also review their systems, do a physical exam, and do any laboratory tests that may be necessary. We also need to be assessing behaviors and attitudes about food and dietary behaviors, physical activity, and then just general attitudes of families about identification of the need to change and a willingness to change. Important with assessing dietary patterns is going to be assessing the quality of the dietary foods that are being consumed, the meal frequency, snacking patterns, therefore getting an idea of the amount of the food, and then we need to consider this in view of the amount of energy expended or the exercise the child has. We're looking at snacks, the frequency of snacks, what they're having, and providing the family with some information about what would be their best choices. An assessment of the physical activity or inactivity is also a necessary part of the initial assessment of the child after we've determined BMI and diagnosis. We need to look at their screen time. Do they have a TV in their room? What are their daily activities? Are they physically active? What do they do as far as social activities? And what is our social community activities available to these children? Are there any barriers for physical activity? Does the family itself engage in physical activities as part of their own recreation and leisure time? And how much time is spent outdoors? Again, a 24-hour recall can be very beneficial. Laboratory testing may be necessary for some children. Some of this is dependent upon the age of the child and their BMI. For children who have a BMI of 85 to 94% without any risk factors, it is recommended that they have a fasting lipid profile and liver enzymes of AST, ALT every 2 years. For children with a BMI that's greater than 95%, it's recommended that they have fasting lipid profile, liver enzymes AST, ALT every 2 years, and a fasting glucose. The laboratory tests indicated are also based on the evaluation of any other clinical signs and symptoms and also family history. When assessing children who are overweight and obese, we also need to consider things outside of nutrition and activity. This slide gives us a depiction of symptoms we may find with possible other etiologies to consider when we are evaluating children who are overweight and obese. Further, we're doing a physical assessment of those children whom we're seeing in our office, and as part of the physical assessment, this particular slide is beneficial in that it suggests things that we need to be considering as possible explanations for what we're finding as we do the physical assessment. For instance, if you drop down to skin and you see acanthosis nigricans, it is a common phenomenon found in obese children, and it should trigger you to think that they may be insulin resistant. Or if it's a female child who may be menstruating and they're having irregular periods, it may be that they have some polycystic ovarian syndrome going on, which can be a complication of the overweight and obesity. Therefore, it gives you some idea of additional testing that may be necessary. I have found that this is a particularly good slide to have a copy of as I'm working with children who are overweight and obese. This particular slide gives us a summary of identification and treatment of children who are overweight and obese. In the first column, we have BMI percentile, which has been overlaid with the ICD-9 code that may be appropriate for that particular percentile. We can look then at the next column, which has to do with medications that might be used, which might be leading the child to be overweight or obese. Some of the symptoms that we may see, in particular overweight and obese categories, some of the family history that we may see, and some of the physical exam findings, which would lead us to what laboratory testing may be necessary. Again, this is a good slide to have when you're working with overweight and obese children to help you work through your evaluation and assessment to lead you to your care planning. Our approach to treating children who are overweight and obesity is then the staged approach, stage 1, 2, 3, and 4. Stage 1 is usually the preventive stage. It's used with children who are of normal weight and children who are overweight or obese who do not have comorbidities or do not need to be instructed in losing weight, just maintaining their weight. It should be a part of each family visit, and the nurse practitioner will visit with the family. The frequency is individualized according to the family needs. Stage 2 is where we have structured weight management. That is on visits, adults or guardians may be present with the children, and it's a time to provide some educational intervention for dietary activity and just general counseling about good nutrition. It is usually a time when young children are needing to be held at their current weight until they grow, or at a time when weight loss is not necessary. It is a time when you sit down and encourage families to self-monitor as far as weight and growth, and also to set some goals and some rewards for not gaining weight or eating appropriately. Usually at the stage 2 approach, visits are back in the office with the nurse practitioner monthly or sometimes more often. It is felt that nurse practitioners, with their knowledge of nutrition and activity and child needs and child development, are effectively armed when they have a guideline to provide appropriate care with stages 1 and 2 for prevention and management of overweight and obese children. In stage 3 of our staged approach, this involves a multidisciplinary obesity care team. Oftentimes that involves physician, nurse, dietitian, exercise trainer, social worker, psychologist. In some of our rural areas, we do not have this capability, and therefore it may involve a dietitian and the nurse practitioner, or just the dietitian. What we're looking at with this is also stressing the same eating and activity goals as we did with stage 2. With the activities within this category, we want to include structured behavioral modification programs that include food and activity monitoring, so journaling and keeping diaries, and the development of short-term dietary and physical activity goals. We also want to do behavioral modification in involving families in the child's need to become more active and perhaps eat better, especially in children who are under the age of 12 years, so that they are seeing the example of their guardians and parents for environmental behavioral learning. We want to train families with regard to activities that are appropriate and will help to maintain appropriate weight while promoting healthy activities. In stage 4, unfortunately, this is usually where there's tertiary care intervention needed, and it's usually a need for a referral to a specialist. It may be a nurse practitioner who specializes in working with children with overweight and obesity, or it may be to a general weight loss clinic specialist. It sometimes involves medications, especially with some of the older children. It can involve very low-calorie diets because weight loss is necessary when we have a child who fits into this category. And it also may involve, for some children, unfortunately, the need for weight control surgery such as gastric bypass or banding. This slide is a part of your pocket reference guide as well, and it provides you with a very quick look at, based on age and BMI, whether or not we should be recommending weight maintenance or weight loss. And it has been adapted from Barlow and Dietz, and it is utilized by the American Academy of Pediatrics. I have mentioned several times that in some cases we maintain a child's weight so they can grow, and in other cases we recommend that children lose weight. This is an obesity algorithm that would be a good thing to have at your hand to refer to. It gives us information about when it is appropriate to recommend weight loss for children as opposed to recommending that they maintain their current weight and we are waiting for a growth spurt. The goal is for weight maintenance or gradual weight loss when the BMI is less than 85 or the 85th percentile, and we usually should not exceed 1 pound per month in children who are aged 2 to 5 years, or 2 pounds per week in older obese children or adolescents, due to the fact that we know that all children are growing and we want to make sure that we maintain their health. When we have children who are overweight and obese and we're working on feeding and eating behavioral intervention, we need to educate on how, when, and where to feed and where eating should take place that would best support healthy growth and development and prevent overweight. We usually stress the need to start the day 7 days a week with a good breakfast. We also stress the need for families to eat together. And one of the devices that has been developed for us as a quick reference to guide our education with parents is 5210, which means 5 or more servings of fruits and vegetables daily, 2 hours or less of recreational screen time daily, 1 hour or more of physical activity daily, and no sugary drinks, water between meals, and low-fat milk at meals. We are all aware that it is much easier to prevent a health problem than to treat a health problem. So for primary prevention for those children who are with a normal weight, a BMI 5 to 84 percentile, we need to promote breastfeeding in infants. We need to also promote diet and physical activities. And again, we want to use the 5210 approach to our message for parents and guardians. The other part of our message to parents and guardians and children as well is that portion size needs to be appropriate for age. The parents also need to be feeling comfortable about the fact that they provide the food and the children can decide what they want. They need to provide children with healthy choices. And exercise can be appropriate in 10 to 15-minute increments rather than in a whole block of 60 minutes. Structurally, parents set up breakfast, family dinners without TV. They limit fast foods, and they encourage outdoor activity. We also need to stress to parents that they have to balance the food groups, limit the refined sugars, and again, stress that screen time has to have alternatives to it. Screen time should not be used for recreational activities primarily. When we're dealing with the overweight category of BMI percentile, that being those who are over the 85th percentile to the 94th percentile, we want to build on the preventive message. Eating behaviors message should be the same with family meals. There's usually not a whole lot that's changed. Again, stressing that parents provide the food so that the children can make healthy decisions. And we have structured activities for children. We need to stress to parents that they provide choices for children that are all good choices, and children will make good decisions and learn how to make good decisions based on that information. When we're working in stage 2 and we're working on prevention plus for those people or children rather who have an overweight BMI of 85th percentile to the 94th percentile, we only change our message and recommend that children have weight loss when there's health risks. Otherwise, our goal and our message is for weight maintenance, and our message is also always using the preventive plus information. The goal will be for the weight maintenance, and so we're waiting for a child to grow into their weight, if you will. For children who are in this category, they need to be seen on a monthly basis, and they should be seen on a monthly basis for 3 to 6 months, depending on the progress that they're making. If there's no improvement after the end of 6 months, then these children need to be referred on to the next stage. For the children in stage 2 who actually should be losing weight, this particular chart provides us with information on their weight loss targets. And again, it's a good thing to copy. It is a part of your quick reference guide. When weight loss is indicated, we need to remember that it should not be more than a pound a month for children who are aged 2 to 11 years of age, or over 2 pounds per week for children who are older. If there's no BMI improvement after 3 to 6 months, then they need to be advanced to stage 3 activities. Overall, as we communicate with parents and guardians, we need to be considerate, and we need to consider the points that are identified here. Our discussion should be positive. We should allow families to have personal choices, just as we're recommending that parents allow children to have good choices. Families need to be encouraged to set specific, achievable goals, and then we need to follow up on the goals that have been set on our subsequent visits. We need to be aware and be culturally competent in the care that we provide, being aware of the cultural norms, the significance that meals and food have for families and the community in which they are living, their beliefs about special foods, and their beliefs about body size and body type. We also need to motivate changes as we talk with parents and provide treatments. We need to advocate for family involvement in the treatment, as it does involve lifestyle changes. And we need to advocate for activities in the community being available for families to take part in. This slide shows you a sample prescription pad that is recommended by the American Academy of Pediatrics to be used in care being provided for children who are overweight and obese. It's felt that by giving a prescription to families, they begin to take the message a lot more seriously. Just as when you give them a prescription for medications, they're more likely to adhere to your recommendations if they are able to have a reference point for the information that you've given them. And this is something that you can feel free to copy and utilize, as it's not copyrighted. Just as a prescription that you may hand a family helps to provide credence to your message about overweight and obesity treatment, so do the scheduling of follow-up visits to address the issue. When you have identified and begun the conversation with families about overweight and obese children, you need to provide appropriate recommendations for follow-up visits to reinforce the message and do follow-ups on your concerns so that you can monitor progress being made. Third-party payment does allow for follow-up visits when overweight and obesity and health conditions related to these have been identified using the appropriate ICD-9 codes. These services are also paid for. As the nurse practitioner role increases in primary care and family practice, therefore, there too, the nurse practitioner role in treating, identifying, and diagnosing overweight and obesity in children is becoming a pivotal point. We're pivotal in the fact that we can teach families and children how to balance quality nutrition with regular physical activity. We can help children and adolescents master the skills necessary to achieve and maintain a healthy weight. We can be the source of referral for children and families for specialty care when this is needed so that they can attain a healthy weight for the child and the family. And we can also become active in the community, advocating for healthy activities for family and children, being available in community activities and resources. Two principles that are central to our quality of care that we provide as nurse practitioners that are very effective when we're dealing with overweight and obese children is the fact that we are educated to provide culturally competent or culturally appropriate care. And this fosters parent and child involvement in efforts to improve the child's health within the context of their families and their communities. And that has to do with the foods that they eat and their physical activities. We also are advocates for our families and patients that we provide care to. And this also encompasses prevention. And we also get involved with advocating for prevention of overweight and obesity as we become involved in what's going on in the schools, the community, and the social environment that may affect our families and children and their ability to obtain the appropriate food and indulge in the appropriate activities to maintain a healthy weight. The approach discussed in this educational presentation can be used by all in primary care as well as pediatric care. The treatment usually involves addressing nutrition and activity and providing supportive education to families. When the situation becomes complicated, referrals are advocated, and the 5210 can be used as a clinical guideline as well as the algorithm that has been presented to you here. As NPs, the goals of our care are to help families and young people develop and sustain the nutrition and physical activity behaviors that will allow them to maintain a normal weight and prevent excessive weight gain. Our other goal is to use a comprehensive, multifaceted approach to impact the epidemic of childhood overweight and obesity. It is known that if we provide and document the care, we are able to obtain reimbursement. But more importantly, we will be making a difference, and our effectiveness will be visible as the outcome of our care is evaluated by others, and they will realize that nurse practitioners are very effective mechanisms in identifying, diagnosing, and treating childhood overweight and obesity. This slide presents the references that have been used to develop this educational tool. I hope you have found this beneficial. Please now refer to the post-education evaluation of your learning tool and complete that and return it. Thank you very much.